now it's time for Astra Symposium, and I would like to introduce my dear colleague, Professor Dr. Nirvana. Her presentation will be on frontline PARP inhibitors in ovarian cancer. Turn up the heat, Astra Symposium.
مساء الخير جميعا. Thank you so much for the organizing committee for inviting me to be with you today. Thanks for Astra for giving me the chance to be in my place with my family, Ain Shams University. Ovarian cancer. Throughout the history, let's go with the history from the first line, chemotherapy, plus or minus beta maintenance, as a frontline treatment for advanced ovarian cancer with a progression-free interval with a median 12 to 24 months. Depending on the outcome of the surgery, we all know that it's very important to have a proper debulking surgery or a proper radical surgery up front, and as the surgery is appropriate, as the progression-free interval is improving, and then symptoms start to occur, to have the recurrence, going to the second line, median decreases into the 8 to 20 months, and then going third line and above 4 months plus. Understanding the DNA repair, here we have two types of repair. The single strand break, it is just a single break in the DNA, where the repair pathway could be with the base excision repair, which is done by the PARP, and then it may progress into double strand repair, which is double strand break, which repairs by the homologous recombination repair, the HRR, or non-homologous end joining. So this is the single strand, which, as we said, the repair occur by the PARP. By the replication, it could cause to double strand break. The double strand break, either the normal cell will cause the repair by the homologous recombination and survive, or the cancer cell will have a deficiency in the homologous repair, so no repair will occur and the cell will die. So upon this mechanism and the DNA repair, long ago, since 2009, the PARP inhibitors have been tested in the olaparib and so on. In 2009, it was the start as the phase 1 pharmacokinetic and pharmacodynamics in the advanced solid tumors, and then in 2002 has a phase 2 for the concept of proof, and then going through phase 3, phase 2 study 19 in the ovarian cancer, and then 2016 solo 2, then 2018 to have the solo 1 and the Paula 1, and 2020. These are all in the ovarian cancer. However, it had been testing in the breast cancer and in pancreatic cancer and prostate cancer. Just to remember, يعني, what is the difference between the germline mutation and the somatic mutation? The germline mutation, it is a mutation which is present in the germ cells. It is in the embryo. All cells in the adult body contain this mutation, and some reproductive cells carry this mutation and is transmitted to the offspring. These are the germline mutation. What is the somatic mutation? It's not a mutation in the germline, it's not in the embryo. It is in the body cells, and it's no reproductive cells carry the mutation. This is the difference between the germline and the somatic mutation. So to go through now, what is the solo one? The solo 1 5-year survival, it tests the 5-year survival for newly diagnosed advanced ovarian cancer. The eligibility criteria was newly diagnosed FIGO stage 3 to 4, high-grade serous or endometrioid ovarian, primary peritoneal or fallopian tube cancer, BRCA mutant, ECOG performance status is 0 to 1, patient who underwent cytoreductive surgery with mainly complete response. They were randomized to receive either olaparib versus the placebo, and the primary endpoint was the progression-free survival, and secondary endpoint was the PFS2 and the time to subsequent therapy and safety. So the primary analysis, it was in May 17 2018, where the median PFS was not reached in the olaparib arm versus 13.8 in the placebo arm. What were the patient characteristics? As we said, most of the patients were BRCA1, 73.5 versus 69.5. Most of the patients have no residual disease, no macroscopic residual disease upon the after surgery. and most of the patient has a clinical complete response. So this study is designed mainly for proper surgery with patients mainly not no residual and with BRCA1 mutation. However, BRCA2 has a percent. However, most of the patients with BRCA2. So upon the results at 7 years in the overall survival, the patient who discontinued treatment before 2 years, we can find that in the placebo arm it was 71, almost 71%. We can find that the completed 2 years of the olaparib, it was 47 versus 26. So the patient in the placebo arm, 26% or the less number who has continued their treatment, and then continued treatment beyond and more, it was 10% versus 2.3, and median duration was 24.6 versus 13.9, and median duration of follow-up for OS, it was almost 89 months. What is the PFS benefit of the maintenance olaparib? It was sustained beyond the treatment, as we see in 12 months, 24 months, 36 months, 48, 60 months, and above. So it maintained the PFS, it was maintained after continuing or after finishing the 2 years and above, with a median PFS 56 versus 13.8. It was, many of the studies have classified here, have classified, sorry. معلش أنا آسفة. Many of the studies have classified the ovarian cancer as a higher risk and lower risk. The higher risk are the patients with stage 4 or stage 3 with residual, and the lower sick FIGO stage 3 without residual. And most of the studies have said that maybe the drug can work in high risk and not work in low risk and so on. So by the stratification of the patient, the PFS benefit of the maintenance olaparib in the higher risk and the low risk, we can see that it caused benefit all throughout the lower risk and the high risk patients. And the descriptive overall survival benefit it provides here, it is not statistically significant, however, it is clinically meaningful. It was 67% versus 46.5 at 84 months. It was not reached as the median versus 75.2, so it has a clinically meaningful, yet it was not statistically significant. And time to subsequent therapy, it was delayed in the olaparib arm, 51.2% versus 22.5, 53 versus 20%. And as we see here that the adverse events, they were comparable, except for it was little higher in the anemia, which is expected with the olaparib or the PARP inhibitors, and little bit with neutropenia. And we'll say later how we are going to manage these side effects. And here again, what about the others throughout the 7 years follow-up? What about the toxicities? We can see here that the adverse events leading to dose interruption, it was slightly higher in the olaparib arm, and leading to dose reduction, it was slightly higher in the olaparib arm. So that's why we need to be cautious with adverse events and treat it properly as early as possible. So the conclusion of the solo one, it was the first study to demonstrate a clinically meaningful overall survival. Definitely it showed improvement in the time to subsequent therapy, and these 7 years it provides that the maintenance olaparib, the benefit it occurs beyond the 2 years, and no new safety signals by the longer follow-up. So this study, the result was to support the maintenance olaparib for the long term, to achieve the long-term remission in BRCA mutant patients. What about the combination? As we all know that we give the beva, taxanes, platinum, and followed by maintenance beva. If the olaparib combined with the beva can do an additional benefit to the beva alone, that's why came the Paula study. It is a phase 3 study, which is the study design, the surgery as a frontline, platinum taxane-based chemotherapy, giving more than or equal 3 cycles of beva. Near patient reaching the complete response or the partial response, they were randomized to receive the maintenance therapy, either beva, olaparib, or placebo and olaparib. And the primary endpoint was the PFS, and the secondary endpoint was the time to subsequent therapy, PFS2, overall survival and quality of life. And here to find that the intention to treat without still the stratification of the BRCA mutant patient, it was 22.1 versus 16.6 in the intention to treat. However, we should know that the patients who were HRD negative in this study, it were only 35%, and the unknown were 18. Otherwise, the rest of the patients, the BRCA mutant 29, the HRD positive 48, and the HRD without the BRCA mutant, there were 19. So when we go for stratification by the BRCA mutation status, we can find clearly there is a big difference between both arms, 94 versus 76, 76 versus 39 at the 2-year, and the median PFS was 37 versus 21 with a hazard ratio 0.31, and it highlights that the combination maintenance of the beva and olaparib, it show a meaningful importance. And what about according to the HRD status? Do we have to have HRD positive, BRCA positive, or both? Which is better? We can see here that the curves, the two lines are separated, both in the HRD positive, including the BRCA mutant, and the HRD positive, excluding the BRCA mutants. However, it was no statistically significant at all in the HRD negative, which showed that there is no benefit of this combination in the HRD negative patients. And the updated PFS, HRD positive, at 5 years, we can see that 46.1 versus 19, which is almost 3 times or approaching 3 times improvement in the 5-year PFS. And 5-year OS, it was still in the intention to treat, no statistical significance, as we see 47.3 versus 41 in the intention to treat. However, they are BRCA mutant or not. However, in the BRCA, in the HRD positive, we can see that the 5-year overall survival, there was still clinically meaningful improvement in the overall survival, 65.5 versus 48. So still the OS, could improve with the combination in the HRD positive subgroup. And here is the overall survival subgroup by the BRCA mutant and HRD. And we can see that both the BRCA mutant and the HRD positive, excluding the BRCA mutant, both show differences in the numbers, 73 versus 53%, and here 54 versus 44%. However, there was the 2 lines were completely overlapping in the HRD negative. And same toxicities as we said before in the solo one, it's in the anemia, we can see that there is an increase in the leukopenia and so on, the same adverse events. However, the adverse events that were almost comparable throughout the PFS analysis, which were in the 2019, PFS2 analysis 2020, and the final OS analysis 2022, they were almost comparable. So the conclusion of the Paula one was that despite 50% in the control, there is an important thing that the control arm, which have the placebo and the beva, they switched to the olaparib upon progression. However, there were a clinically meaningful overall survival benefit in the patient with HRD positive. 5-year overall survival rate, it was 65.5% versus 48.4%. No overall survival benefit, definitely it was observed in the HRD negative. No new adverse events shown with the longer follow-up. So this data confirmed the addition of olaparib to beva as a standard of care for HRD positive patients in this setting, and it's important to guide our treatment decisions. What about the adverse events? As we said, that one of the most important adverse events, we are all dealing with the PARP inhibitor, the anemia, so it's important to know when to catch the anemia and how to treat it early. It's very important to monitor the CBC or the blood count monthly during the olaparib, not to go for the patient to go after 2 or 3 months or so on. Monthly CBC should be done, and the anemia should be corrected as early as possible. If the anemia of the hemoglobin is less than 8, we can go for the blood transfusions. And if the first occurrence, you can restart again with the same dose. If it occurs once and then corrected, we can go back to the same dose. However, if it is repeated upon the second time, you can go for the dose reduction. And what if this anemia increases? We don't often relate it to the drug. If you find that the anemia is persistent, please go for bone marrow analysis and try to search for another cause of anemia if you find there is a persistent anemia. And here it's the same, we have to rule out other causes. It can manage with dose interruption or dose modification, and if the time increase, refer to the hematologist. What about the nausea and vomiting? Still, the patients on the PARP inhibitors of the olaparib can experience nausea and vomiting, so the patient counseling is important to give antiemetics. And at some extent, we can do dose interruption if the patient is taking the tablets and still vomiting, so you can do dose interruption or dose reduction if it is grade 3 and so on. Dysgeusia, and there is a change in the taste. We have to instruct the patient for good hygiene and for the timing of the medication. Don't to take the medication with the meal, to have proper spacing, and same for the dyspepsia. Don't forget the PPIs and the H2 antagonists. So, what is the summary? The PARP inhibitors, it is a new class of drug targeting DNA repair pathways. The HRD, the homologous recombination deficiency, is a phenotype marker, and please try to do it as early as possible. With the diagnosis, at the beginning of the diagnosis of the patients with advanced ovarian cancer, go for the BRCA testing or the HRD testing to plan the management of your patient after the patient is getting with you a complete response or partial response in the platinum-based treatment. Highest level of activity, the highest level of the activity, BRCA mutant patient have a better response than non-BRCA mutant patient. Biomarker setting is key in selecting patients for first-line maintenance therapy and identifying unaffected family members. In recurrent ovarian cancer, maintenance olaparib has shown clinically significant extension in the progression-free survival and clinically meaningful in overall survival benefit. In the frontline treatment with in the patients with BRCA mutation, olaparib has led to a major improvement in the PFS, with 48% of patients progression-free at 5 years, and in this category of patients, this is a great number. In frontline treatment of patients with HRD, olaparib added to beva led to improvement in the PFS 37 months and the PFS2 and the overall response rate with no safety reports, no longer follow-up. However, you have to do, as we said, to catch the adverse events, mainly anemia, earlier and try to treat it earlier so that not to go to a higher grade. Thank you so much for your time.